We're going to do the Choosing Wisely section. This is a whole bunch of other doctors telling us what they think we ought to do or not do. And it's interesting because so much of what they've recommended in their Choosing Wisely applies to emergency medicine and would also apply to primary care doctors. What they're supposed to do is say, here's 5 things that our doctors should do. You know, the idea of Choosing Wisely was the American Board of Internal Medicine Foundation said, let's have an initiative where all the medical societies come up with 5 things that they think are probably overdone, don't need to do, and list them. That doesn't mean that you can't ever do them, but and these are things would be certainly under the issue of this shared decision making because they may not be very useful to do. And so I went through, there are 42 medical societies who have given their 5 things in. There's another 20 pending. They have gotten everybody to sign on to this. It's like apple pie and motherhood. If you don't sign on to this, you're going to be viewed as some kind of weirdo medical society. As a matter of fact, the American College of Emergency Physicians refused to participate in Choosing Wisely. And at the ACEP Council meeting last year, a lot of the former leaders of ACEP, presidents, things like that, got up there and said, here are all the reasons that we should not participate. If we list these 5 things, we won't get paid for them. If we do these 5 things, we're going to get sued. There was like one horror story after the other. And so at the council meeting, they voted like 60-40 to not participate. So they were actively choosing to stand on the sidelines when everybody else was going to play ball. I told them I was embarrassed by what they did. I spoke before the council and said, this is not where we should be. And 2 or 3 months later, the board said, okay, let's do it. And they came up with 5. Frankly, they were all softballs. None of them really had a lot of schmaltz behind it. But anyway, I've gone through all of them, and I've looked at the ones that relate to us. Number 1 this is from the American Academy of Pediatrics. They say CT scans are not necessary in the routine evaluation of abdominal pain. Well, who's going to argue with that? That's a softball. I did want to get some supplemental information to kind of, beef that up a little bit. We did a paper in January of this year. It was in JAMA Pediatrics. The way they changed all the names of the JAMA papers. And it said, of the 85 million CTs done in 2011, 85 million, 5 to 11% were done in kids. They said up to a quarter of abdominal CTs, catch this, a quarter of abdominal CTs, 8% of chest CTs, 14 of spine CTs delivered an effective radiation dose of 20 millisieverts or more. 20 millisieverts is huge. Normally we talk about 10 and 10 for the belly, 10 for the chest. But they're saying a substantial subset are getting large doses. It's projected in this paper that CT scans would cause 4,870 future cancers. That's a year, 4,000 cancers more a year. And we talk about confidence intervals. They said it was 4,800. The confidence intervals went, the 95% chance that that's the number, it went from 2,600 to 9,000. But basically they said it was about 4,800. 43% of the cancers could be prevented by reductions in the highest radiation of the top 25%. If you could take the top 25% in terms of the highest radiation and just drop those alone, you would cut down on cancer risk by 43%. If 1/3 of the CTs in children are believed unnecessary, which I'm sure they are, then this would further decrease the risk. So everybody keeps on talking about the risk of cancer, and they try to extrapolate it from Hiroshima data and things like that. We don't really have a randomized double-blind, and we never will. But there was an interesting paper from Australia by Dr. Matthews in the British Medical Journal in 2013, where they looked at 680,000 people who had CTs between the ages of 0 and 19, and they followed them for 9.5 years. And they compared them with a similar number, actually more number, of patients who never had a CT, and said, let's look at how many more cancers existed in this group, if any. 24% more cancers, 24% more cancers. Now remember, these are young people, 0 to 19. 680,000 of them followed for 9.5 years. That's only 9.5 years. What about the next 10 or 10 and 20 and 30 and 40 years where these cancers may develop? Anyway, that's what they concluded. And in this study, they said that the average dose of radiation that occurred in these patients was 4.5 millisieverts, which is a fraction of what these other people said were being given out. So we'll never have a randomized double-blind trial where we say we're going to give you a CT and see what happens to you, and you're not. Because the people who had CTs, maybe there's some reason that they had cancer. Maybe that's why they got a CT. Maybe they were prone to some illness that caused cancer. So you certainly can't say causality, but you certainly can say association. So that was the first study that's really put a number on it. CTs, no CTs. It turns out that if you look at it on it turns out to be 1 per 1,100. 1 per 1,100 is a lot more than people had thought. The usual estimate is like 1 per 2,000, but these are kids. So kids basically are going to be much more susceptible. So if you take a number across the board, maybe 1 in 2,000 will get cancer. These kids, 1 in 1,100 got cancer. But we just did a paper in the abstract. Those of you who are subscribers, this was in the May issue. This is from a guy by the name of Patrick McLaughlin. He's a radiologist at Vancouver General Hospital, talking about the use of the title is The Emergence of Ultra-Low Dose CTs and the Impending Obsolescence of the Plain Radiograph. The impending obsolescence of the plain radiograph. And there's a question mark after that. And in this article, he gives examples of what they've been able to do there in terms of reducing doses. Let me give you a couple examples. An ultra-low dose CT of the cervical spine in a 28-year-old pregnant female was performed at an effective radiation dose of, catch this, 0.6 millisieverts compared to 6 millisieverts, which would normally be done. They got it down by a factor of 10-fold. 0.6 millisieverts is a hiccup in terms of radiation. The effective radiation dose for an ultra-low dose CT of the chest was 0.5. Nobody's ever heard of numbers this low. 0.5. Compared to 7 millisieverts as the standard dose. The effective radiation dose for ultra-low dose coronary CT, 1 millisievert. Unheard of. Coronary CT, 1 millisievert. To put that in perspective, a chest x-ray is 0.1 millisievert, a tenth of that. I'll give you one more here for, there's one here where the CT is less than, okay, here, I think this is it. An ultra-low dose CT performed to visualize a renal calculus at an effective radiation dose of 0.4 compared to an average dose of 0.7 for an abdominal x-ray. The abdominal x-ray is 0.7, the CT is 0.4. So these guys are saying if you do these kinds of things and we're getting to radiation doses that are comparable to plain x-rays. And since CT is better than any, plain x-rays on everything kind of thing, now this is obviously a little tongue-in-cheek, but this is kind of where this can go. And Jerry's point of view on this is, God, this is the last thing we want to have happen. Because if we have no radiation dose being given by CTs, then CTs will be done, then we'll find all of these incidental findings kind of thing, and we'll go down this path, and you'll need this test and that test, and although the CT didn't kill you, this test will, kind of thing. So he says, this is bad, don't tell him about this. What's my view? I think it's fabulous. And I interview this radiologist. Those of you who get the abstracts know that we do interviews now. So I called this guy up. We did a Skype interview with this fellow. And I said, well, can my hospital do this kind of thing? Because it turns out they have a relationship with Siemens. And so the idea is, and he said, yes, this can be done. This is Vancouver General. It's not a secret process or different. They explain it in the paper how they go about it. They do 3 different things, and they're coming up with radiation doses that are a tenth of what is normally being given out there. Now I did acknowledge it, and I did see the papers, and you have to give up some clarity. You have to give up some. It's not like super clear, kind of thing. But it was clear enough for them to get the job done and look at what they were looking for. Moving on, don't perform cardiac imaging for patients who are at low risk. This gets into this issue of what's the return on investment. Peter Bicellio, who's really known pretty well in emergency medicine, Peter did a study in the Journal of the American College of Cardiology. It was published in August of 2013. 894 patients with negative EKGs, chest pain, low risk chest pain. They had negative EKGs and negative troponins serially. And they basically did CT angiograms in 894 patients, negative EKG and negative troponins. How many MIs were out of that 894? Three. And those 3 MIs were picked up early on. And so what he concluded was, the paper concluded that we can get you out of the emergency department quicker if we do a CT angiogram. That was the conclusion. Now they did almost 900 CT angiograms and picked up 3 MIs. So the real gist of that paper is, this is the things that Jerry's talking about is, and when we interviewed Peter, it was like, Peter, you did 900 CT angiograms and picked up 3 MIs? Aren't you embarrassed that you did that, and then you published this paper saying how bad you were, kind of thing? He said, well, I must admit it was clearly overdone. But these people did not come back to the hospital with repeat complaints. There were some downstream things that they said were good, but in terms of they kind of felt more confident in their diagnosis, et cetera. But it was really pretty bad. Another thing they said here is don't do workups for clotting disorders where you're starting to do all of these kind of factor 5s and protein Cs and S deficiencies, because they won't alter treatment, especially if you know the cause of this clotting disorder. Somebody got kicked in the calf or something like that. We have a tendency to kind of want to do thorough workups. They said they won't change anything. Don't bother doing it, especially when you know the cause. Avoid transfusions of red cells for arbitrary hemoglobins or hematocrits. This was kind of interesting because the American Blood Banking Association is trying to get us to be very conservative about the use of blood, particularly in people who are stable. So they come in, you have a stable person, but their hemoglobin is 6 or 7, that maybe they don't need any transfusions because, and I never really thought about it like this, transfusions should be considered liquid organ transplants. Have you ever considered a transfusion to be a liquid organ transplant? Well, it is kind of thing. And they've matched you. Your ABO type and all this other stuff has been matched kind of thing. So that's your donor is going to give you this liquid organ transplant. And we know that transplants, come with some risks. And these risks, we're not talking about, the risk of transfusion reactions or catching HIV or anything like that. We're talking about risks that have really not been considered to be associated with blood transfusions, but we do know that they're associated with transfusions of or other organ transplants. Transfusions are being associated with harm regarding the immunologic suppression that has been associated with their coming on, and increased long-term mortality. There was an article in the New England Journal. Patients receiving blood more than 2 weeks old were almost 70% more likely to die within a year versus those receiving fresher blood. If you have cardiac surgery, who gets blood, the mortality is twice that of people who don't get blood, all things being equal. There's a suggestion that transfusions can induce autoimmune diseases. There's mounting evidence that patients who receive transfusions do worse than those who don't. As an example, the risk of an infection after orthopedic surgery in patients who receive blood is 1.5 to 3.5 times greater than those who do not get blood. Is that weird or what? The risk of infection is 1.5 to 3.5 times greater in people who get blood than not. And animal studies have indicated that malignancies progress faster in rats who've given stored blood. Now that's a rat study, but there are some human papers that suggest that if you get a cancer surgery, and in the process of getting cancer surgery, you get blood, that you will do worse than those who do not get blood. And this relates to perhaps this idea of immunosuppression that, as a result of this liquid organ transplant. Number 8 is don't use continuous telemetry monitoring outside of the ICU without using a protocol that governs continuation. We did a whole half hour on the worthlessness of telemetry. And even in low-risk chest pain patients, they were talking about the worthlessness of telemetry. But the suggestion here is hospitals really ought to have protocols on who goes there, unless your hospital has solved the problem by putting every soul in every bed has telemetry. But the literature is surprisingly robust on the lack of value of telemetry. There's a bunch of papers here on ENT things, number 9 through 12. Let me just summarize those. Rhino sinusitis is a cold, and 0.5 to 2% of people who get rhino sinusitis will develop a bacterial sinus infection. And the idea is you get a cold lasts basically a week. And at the end of that week, your sneezing stops and your coughing stops, kind of thing. And if your sinuses are still bothering you into the second week, it is believed that the transition has occurred from a viral disorder of the sinuses to a bacterial infection of the sinuses. And the 3 causes of bacterial infections of the sinuses are the 3 causes of otitis media. Strep pneumo is number 1, H. influenza is number 2, and M. catarrhalis is number 3, a long distance. So whenever you clog up a hollow chamber in the head, it gets infected by the same 3 bugs. So you clog up the ear, eustachian tube, those 3 bugs. Clog up the sinuses, those 3 bugs. And it's unusual. The sinuses are usually sterile. They get these tiny little holes, and somehow they stay sterile. So you get a viral infection in them, the stuff gets trapped in there, you get edema, the sinuses can't drain, you get an infection. It's the same thing. You get your gallbladder clogged up, you get an infection. You get your appendix, it's all the same mechanism. What else did they say? Imaging of sinuses, unnecessary. Use amoxicillin if you're going to treat. That's a nice cheap drug. Don't use antibiotics for bronchitis. Nobody's going to argue with that, or viral pharyngitis. So the idea, you guys have heard this before, the word bronchitis is being struck from the medical literature. It is removed. And the new word for bronchitis is chest cold. Exactly. Thank God it's only a chest cold, doctor. I thought it was bronchitis. No, we got it early. We nipped it in the bud. It's only a chest cold. Oh, okay, I understand that. I thought it was bronchitis because I know for bronchitis that used to give me the Z-Pack 3 times a year. We really created a lot of bears who come back to be fed regularly. That covers 9 to 12. Okay, 13. Don't prescribe antibiotics for otitis media in kids age 2 to 12, a non-severe disorder. This is the American Academy of Family Physicians using the old criteria developed by the American Academy of Pediatrics for otitis media. I like the idea of observation in cases where there's diagnostic uncertainty. When you read the current recommendations, there is no such thing as diagnostic uncertainty. You either make the diagnosis or you don't, which is obviously not very practical at all. Cough and cold medicines is 14. That's an obvious kind of thing. 15, don't order CT of the head for, no, that's too obvious. 16, don't prescribe oral antibiotics. This is a great one. Don't prescribe oral antibiotics for uncomplicated acute tympanostomy tube otorrhea. So you got a kid who's got tubes in his ears, and parents bring him in because there's pus coming out now. So they say don't prescribe oral antibiotics. And that was from the American Academy of Otolaryngology, Head and Neck Surgery. However, there's a great, great paper that came out, New England Journal, February 20th of this year. Is my time up, Jerry? So this New England Journal paper, it was about otorrhea and kids, and they compared drops, antibiotic drops, augmentin, and observation. The drops were hydrocortisone, bacitracin, which is basically cordyceps. It's called cordyceps TC. So you put these odor drops in. They compared that with augmentin versus observation. On every measure of success, the drops worked best by far. At 2 weeks, persistence of the otorrhea, 5% within the kids who got drops, 44% in the kids who got augmentin, 55% in the kids who were observed. Slam dunk, no question. Next time a kid comes in, a draining ear, they get the cordyceps drops, no oral antibiotics. This is a powerful study, basically made the answer there.
We have one saying the same thing this month. We have one this month saying the same.
This may be that one, because it came out February 20th.
No, we have one this month.
Well, it better say the same thing. Damn it. Okay. And then 17, don't prescribe oral antibiotics for uncomplicated acute external otitis. So that's supposedly you use your drops with the steroids and the antibiotic and clears it up. But you must admit, though, you have seen people who have had really, really nasty external otitis, where you really feel, you know, I think I like to give an antibiotic as well. The key there is don't give Keflex. Don't give an anti-staph drug, because that's not, the cause of these infections is Pseudomonas, Pseudomonas, Pseudomonas. Exactly. So you have to use an anti-Pseudomonas drug. That's Cipro. So Cipro is what you use for these. Yeah, that'll catch a little staph too, but it won't. Keflex will not kill Pseudomonas. The next ones are basically 18 to 21, and we'll stop there, is on lab testing. And let me distill the 18 to 21. History and physical, in conjunction with the surgery that is being performed, should determine what test, if any, you should get in terms of preoperative testing. All of these papers in here are basically saying back off of knee-jerk preoperative testing and do it based on history, physical, and what surgery is going to be performed, whether it's urgent or elective, those kinds of things. And ER doctors basically aid and abet preoperative testing, because they say, oh, they're going to want this chest X-ray, oh, they're going to want all this, all that. And we get all of this test thinking that the surgeons are going, how proud that you got all that for us. No. Basically, it really needed to be focused on why do we need to get it. I can tell you that I remember a case in our hospital where a kid had a supracondylar fracture, just needed a pin put in it. They would not let the kid come into the operating room without a UA. It's like, honest to God, they would not. I talked directly to the anesthesiologist. No, it's just a little pin. You'll be here 2 minutes. She said, no UA, don't send them. Obviously, nitrous oxide toxic over all of these years, was reflecting her mentation.
The kid broke his elbow because he fell down because of his
urine, absolutely.
You know that?
And this would be down a jury's line, because if you do enough tests, statistically you'll find some abnormal tests. Routine testing influences the management of surgery in under 3% of cases, and even then you would wonder if that's really appropriate. And
all right, we got it. Why don't you join me with this?
what are you doing?
We're doing a visual diagnosis.
I usually do that.
Let's do it together.
Do you know how to do this?
You can do it.
Do you know how to do it?
No.
All right, then I'll do it.
Okay.
I want to see.
Sent me home 2 hours
I want to
ago.
see how you do this.
All right, well, you can help me with it.